So since it's 5 after the half hour, I'm going to go ahead and get started. It's really nice to see so many folks here. Um, this is the latest lecture in a lecture series that's being sponsored by the Johns Hopkins Center for Global Emergency Care. The topic of this lecture series is emerging threats for the frontline provider. And we're talking about emerging and re-emerging infectious disease threats that are relevant to emergency physicians, taking care of adult and pediatric patients on the front line. Previous lectures have spoken about Mpox, Ebola viral disease, and future lectures have topics that will be distributed, so stay tuned. Today, we're going to be talking about measles, and I hope that the material that I have for everybody is something that's going to provide you with something of a little bit of interest, given that current measles cases are at a pretty staggeringly high rate, given that we're only in the third day of the third month of 2025. So a tiny bit of background before we jump into it. Why are we talking about emerging threats? So it ain't over till it's over, but it's never over is a thing that infectious disease geeks like to say about emerging and re-emerging infectious diseases. Many, many years ago, the philosopher Seneca in ancient Rome said about infectious disease that you won't be surprised that diseases are innumerable. All you've got to do is count the cooks. So when we think about specifically the subset of infectious disease that we think of as emerging threats, these are new infections or re-emerging old infections that are often the result of human interactions with or encroachment on nature. So human societies are continually expanding. We have a progressively interconnected world. There's perturbations of the human-animal interface, less relevant for measles, which is a human-only disease, but often relevant for many of our infectious diseases that are zoonoses. And as all of this progressive interconnection happens, as there's increasing vaccine hesitancy for vaccine-preventable diseases like measles, there's opportunities that are created for unstable infectious agents to emerge, jump species sometimes, adapt to spread among humans, as in the case of highly pathogenic avian influenza, which is another prior topic, and just spread more and more. Emerging threats historically are challenging to predict in advance. And when you hear somebody predicting the next big pandemic, I want you to be a little skeptical of that because infectious disease geeks have mostly been wrong when we've predicted that. But what we mean by an emerging threat is something that's suddenly increasing in caseload or geographic spread or incidence. Sometimes these are novel pathogens, sometimes they're re-emerging or resurgent pathogens, as in the case of measles, which is what we're going to talk about today. And sometimes they're deliberately emerging. That's the case when we talk about things that are bioterror threats. Often, the expansion of an emerging threat depends on a system that is fragile in some way. So surveillance and response depend on frontline providers like you and me to recognize, flag, and respond to emerging threats, or oftentimes they can circulate under the radar. When we talk about measles, we've unfortunately got both of these systems in play, that there's some fragility to our system based on vaccine hesitancy, and that we're seeing marked increases. This is not a normal measles year. So who am I and why am I talking to you about measles or infectious disease at all? I'm an enthusiastic educator. Anybody who knows me can speak to that. And I'm the education lead for the Johns Hopkins Center for Global Emergency Care. I'm also the EM clerkship co-director at our institution. I'm a tropical medicine geek and I'm ASTMH certified in clinical tropical medicine and traveler's health. And I'm interested in time-sensitive learning. What does it take to help people know the things that they need to do their job just before they need them? I'm a fellow frontline physician. I work a full clinical burden as a nocturnist in a high needs region of Baltimore, Maryland, here in the US, as do I know many of you. So let's get into it. Let's talk about measles. So measles has had routine reporting of its incidence in the United States from 1912 onward. It's one of our earliest reportable diseases. And when we think about our pre-vaccine incidence, in 1958, there were more than 700,000 cases per year in the US. So this was historically an incredibly significant source of predominantly pediatric illness and disease. Severe disease is most common in littles and bigs, so children under the age of 5 and adults over the age of 20, accounting for about 52% in the under 5 group and 39% in the over 20 age group of the measles hospitalizations in the US last year. The last non-pediatric US measles death was in a woman in 2015. The last pediatrics measles death was last week in Texas. Measles is so contagious. It's so contagious that if a person with measles were to walk into a small room and then leave for the next 2 hours, anybody who walked into that room who's not vaccinated could get measles. That means that if unvaccinated people are around someone who has measles, like being caregivers for a child with measles, we estimate that about 12 to 18 of the people who are in contact with that infectious source will be infected by a single person. And about 9 out of every 10 unvaccinated people who are exposed to someone who's infectious will become infected. So about 48,000 people were hospitalized and about 500 people died in the US of measles every year prior to vaccination. Since vaccination has occurred, cases dropped precipitously. But from the year 2000 onward, outbreaks in the US have undergone a pretty consistent pattern, which is that outbreaks start with a travel-associated case. That travel-associated case returns to a community, often a close-knit community with significant rates of vaccine hesitancy or low vaccination rates overall. Once that happens, we see intense clustering of cases. The spectrum of a disease for measles is really wide. The classic clinical presentation you learned in medical school probably or in nursing school, you get cough, coryza, and conjunctivitis. That's your classic 3 Cs. You get a really high fever. And the rash only starts after you've been infectious for about 4 days. That's that classic morbilliform rash. And don't worry, if you don't 100% remember what it looks like, we're going to do a lot of visual learning today. Most people who get measles will be okay, but measles-associated pneumonitis, other pulmonary complications, and other neurologic complications like post-infectious encephalomyelitis are the main source of morbidity and mortality. All of the people who are hospitalized in the current Texas outbreak are hospitalized because they have hypoxemia or pulmonary symptoms. So pulmonary complications of measles can be quite serious and require hospitalization. We've talked a little bit about transmission. I'd like to talk a little bit more about it and talk to you guys about something called the R0 number. The R0 number is, on average, if there's a susceptible population, how many people will a given infectious disease onward transmit to? So for things that we're aware of, like Ebola, which we talked about Ebola viral disease just a couple months ago, it's about 2, right? 2 additional people will get Ebola from every infected person. And that's a pretty infectious illness, right? COVID pre-vaccine, it was about 3, and that was distressing. SARS and HIV, especially if it goes undiagnosed for some time, the R0 is typically around 4. Chickenpox is much more infectious than that. That typically infects about 12 people. Mumps, another vaccine preventable illness, typically affects about 14, which is highly infectious. Whereas measles is one of the most contagious illnesses that we know in humans. And a single infected person, on average, will affect up to 18 additional people. When we zoom in on the situation report for measles cases in the United States, and we zoom in just in the area immediately prior to vaccination onward through 2020, what we see is that after vaccine licensure, cases dropped dramatically. So there were around 450 measles deaths a year between 1956 and 1960. That came out to about 1 death for every 1,000 cases. And at that time, it was estimated that more than 95% of Americans had been infected by measles by the age of 15. We achieved measles elimination status in the United States in the year 2000. And that was after, in 1989, a second dose of measles vaccine was incorporated into the vaccine regimen, which means that most children who elect to get fully vaccinated or whose parents elect to fully vaccinate them get a first dose somewhere around their first birthday and a second dose sometime before starting kindergarten. So first dose somewhere around 12 months of age, second dose somewhere between 4 and 5 years of age. That resulted in a significant diminishment of cases that had started to tick up in the late 80s and early 90s. It also means, however, that some people who were young in the early 80s to early 90s may have only received a single dose series and may not have as good of immunity as people who have been vaccinated from 1990 onward. When we zoom in still further from 2000 onward, what we see is that after measles elimination was declared, there have still been a couple of big outbreaks. So 2014 saw a large number of imported cases, followed by a multi-hundred case cluster, unfortunately centered around the amusement park Disneyland. There were additional large case clusters in 2018, and that large case cluster in 2018 actually bled into 2019. The last very bad epidemic in the United States was in that 1989 to 1991 band. There was a total of 55,000 cases over that entire 3-year band, and about 123 children died during that infection. That was the impetus for the second dose being added to the vaccine schedule. What I'd like you to notice from this bar graph, which takes us from 1992, so after that last bad epidemic, into the current year, is that the numbers that we're seeing so far as of the end of February are very atypical. This is a much higher measles case count, particularly because the vast majority of the cases are coming from a single cluster than we typically see in an average year. The other thing that I want to mention is that measles is just a plane flight away for most of the United States. There's still a very significant measles burden throughout the world. And when there's pockets of low vaccination in communities all over the US, it's not really a matter of if there'll be another measles outbreak. It's a matter of when the next big measles outbreak will be. The US vaccination rates for measles have declined remarkably since 2010. Exemptions from childhood vaccinations, including non-medical exemptions, have decreased markedly, and there's been a particularly high increase since 2020. And because of that, what we see is that while previously, when 95% of the population was vaccinated, someone who had measles who came back to their community was likely to infect only 0 to 1 people. If there's no one vaccinated, they're going to infect up to 20. If there's a low vaccination rate, like what there is in Ford County, which is where the current case cluster is in Texas, they may infect 5, 6, 7 people. This growth in vaccine exemptions has affected the measles vaccine particularly, in part because a lot of misinformation centering and exploiting vaccine hesitancy has been about the measles vaccine particularly. I'm going to talk about the measles vaccine and side effects from the measles vaccine as we go on today. Why, you might ask, is there so much focus on this one outbreak in Texas? So it's an exemplar of what we can expect to see if vaccine hesitancy continues at the rate that it's been. The outbreak is occurring in a rural, tight-knit, low vaccination community. Previous large outbreaks have occurred in similar communities, but the overall vaccine prevalence across the US is now so low, the risk of nationwide spread is actually much, much higher. There's worrisome demographics in that community. Measles is at its most lethal in young children, and the vast majority of the cases that are being hospitalized and cared for right now are unvaccinated. I should say all of the hospitalized cases are unvaccinated. There's increasing data since the last very bad measles year in the United States about this thing called immune amnesia. So there's improved data about that. It looks like immune amnesia means that, which is a measles-induced condition that I'm going to talk more about in a few minutes, children who survive measles are probably at enhanced risk from other important infections, including COVID and influenza, for months to years after surviving measles. So it's not just that they get the infection and then they're fine. There's serious complications even in patients who appear to have done well. Additionally, the source of the outbreak is not yet verified, and that's contributing to some degree of vaccine hesitancy in the community. There's also a lot of social media chatter around a low community concept of the potential severity of a bad measles outbreak. And I would say that that's probably pretty true in a lot of the United States. A lot of people have never seen measles and have a relatively low concept of how bad it can be. A lot of clinicians have a relatively limited concept of that, having learned about it only from textbooks. So we're going to try to talk a little bit about that today as well. This is a map of the Texas county where the measles outbreak started and shows the kindergarten MMR, which is the measles, mumps, rubella vaccination rates in the past year. We can see that this is a low vaccination pocket, but it's certainly not the only one. And while vaccine hesitancy on the part of caregivers does play a role, so does access issues. The United States is a place that does not have universal access to vaccination in all parts of the country that is equal, and that is certainly true in Texas as well. 140 of the 164 cases so far this year are in Texas. This year's case count has already passed 8 out of the last 15 annual counts, and as I said we're only 3 months in, not even. We just finished our second month. There are cases in Alaska, California, Georgia, New Jersey, New Mexico, New York, and Rhode Island, in addition to Texas, but the vast majority of the cases are in this Texas cluster. We do see that the slope of the curve of infection rates maybe is starting to slow down in the last few days. It may just be wishful thinking on everyone's part, but it does seem like the curve, which was almost a straight vertical line, is maybe flattening slightly, which would be wonderful. What we see here in the Texas case count by county is that of the 146 cases, most of them are in Gaines County, some of them are in Terry County, but because there's interstate mobility within Texas, as there is in most of the United States, we are seeing cases in multiple other counties. We're also seeing that the case burden is decidedly pediatric. So 46 of the cases have been in small children 4 and under, 70 of the cases have been in children 17 and under, and the vast majority are not vaccinated or have unknown vaccine status. The reason that you'll hear me harping on vaccine status today is that when we talk about measles as a vaccine preventable disease, this is the biggest public health intervention that can be done to help prevent massive measles outbreaks. State level data, which is what is often reported and shown in lectures like this, tends to hide pockets of very, very high non-medical vaccine exemption rates. So this QR code will take you to some additional details about this, but this is a map of several states' variability in their vaccine exemption rates, ranging from relatively low to quite high. And what we see is that nationwide, it's just risen year on year on year. From 2013 to 2023, the vaccine exemption rates in kindergartners have crawled point by point higher and higher. That means that these are kindergartners who do not have full series of vaccines, very likely to include not a full series of their measles, mumps, and rubella vaccine. The same story is true globally. So despite the fact that the vaccine is safe and effective, measles cases have increased year on year for the last decade or so. Much of the progress that was made towards eliminating measles from 2000 to 2019 was on the basis of vaccine uptake. The global vaccine uptake hit 86% in 2019, but then during the COVID-19 pandemic dropped to 81%, which is the lowest that it had been since 2008. And the coverage in low-income countries has fallen to 67% in 2021 and dropped to 66% in 2022. That means that the 9 million cases that occur worldwide annually and the about 140,000 people who die of measles did not have to. Those people could have accessed a vaccine. Just more data showing that the rates continue to increase worldwide. So what are our big fears with a large measles outbreak here in the United States? So fear number one is the potential loss of elimination status. The first Trump administration had proactive messaging in support of measles vaccination during a large outbreak that occurred in 2019. It is possible to control the outbreak that's occurring now. It's not inevitable that it's going to develop nationwide spread, but if this isn't controlled, the US is at very high risk of losing our measles elimination status, which as a country we've had for 25 years, and for individual people provides them a freedom to move about the planet that I suspect people would miss should the United States lose its measles elimination status. In addition, there's data from around the world that suggests that other countries, including those that have been able to achieve lower measles mortality rates, even those in resource-constrained health systems, have seen measles mortality jump in the setting of large epidemics. Why? Predominantly because of overcrowding. Because measles can generate so many cases in such a short time, even sophisticated healthcare centers can be overwhelmed. And that's a very real risk should measles start to spread in a very widespread way, again, in the United States. What's the public prevention message that's going out right now? So it centers on vaccination. There are state-based efforts to improve vaccination rates that are ongoing. Unfortunately, there's limited national support. There's limited targeting of vaccine hesitant families. some things to advocate for if you are somebody who lives in the public health advocacy world is reporting of and tracking of vaccine uptake rates at the county or zip code level rather than at the state level, because vaccine hesitancy is not a monolith. Communities are hesitant for very diverse reasons, and targeted messaging to help prevent child and infant deaths from vaccine preventable diseases have to be about the reasons that that individual community has been hesitant to uptake them. Monitoring is critically important, as it is in all infectious diseases, and having a bureaucratic nationwide system that helps do that is critical, as is public education on symptoms. So educating not just parents and families, but also healthcare providers who may have never seen measles and not know a whole lot about it. The MMR vaccine does have some mild side effects. So mild rashes occur about 1 in 20. Fever occurs post-vaccination in about 1 in 6. But severe allergic reactions happen less than 1 in a million cases. In contrast, about 1 in every 20 children who gets measles will get pneumonia. About 1 in every 1,000 children who gets measles will get encephalitis. And about 1 or 2 out of every 1,000 children will die. Those are odds where I know that for my children, I would certainly pick vaccination. And if there's a parent who wouldn't, it's important to understand the reasons why, because most parents, most places, most of the time want their children to live and thrive and do well. I'm going to pivot here from the public health focus at the beginning of our chat to talking with a more clinical focus. So our basics from medical school is this, right? So measles is highly contagious, as we've discussed. It starts with those 3 C's. That's our conjunctivitis, our coryzal symptoms, and we sometimes, before the patient develops a rash, can find this pathognomonic finding known as a Koplik spot. I'm going to show a bunch of examples of Koplik spots because in talking with trainees over the past couple of weeks, I've discovered that lots of people don't know what they look like. Once the patient has a rash, they've already been infectious for 4 days, but they're going to be infectious for 4 days more. So being able to recognize the rash as not just a generic viral exanthem, but as the pathognomonic mobiliform rash of measles is another really important skill that we're going to spend a little bit of time on. A tiny bit of history. I won't spend a lot of time on this, but Henry Koplik is the person who Koplik spots are named after. He began his practice in 1887 at the Good Samaritan Dispensary, which was in New York City's Lower East Side. He worked with some of the city's poorest residents and their children, predominantly the community that he served was Eastern European Jewish immigrants who were living in very overcrowded tenements. He spent the entire time from 1887 to around 1896 dedicating his care to these patients and thinking about what can we do to improve the care of measles. When he defined Koplik spots, which appear about 2 to 3 days before the rash does, he allowed generations of physicians to identify these contagious children that much longer before they broke out in the rash, and to facilitate isolation and stemming the tide of big measles outbreaks. So just to hammer that point home, after exposure to the time of onset of rash, typically is a 14-day incubation period. But the patient is infectious from 4 days before the rash shows up until 4 days after the rash has shown up. And so catching these cases 2 or even 3 days early really makes a big difference. The fever typically starts to get high around the same time that the patient presents for care. So fever is low on the first couple of days, and the kiddo with measles is probably just going to seem kind of snotty or unwell. You can see from the fever curve on the right that it's not particularly high, it's not particularly dramatic. On day 3 and 4 of illness, though, which is when Koplik spots are likely to be found, but right as rash is sort of thinking about showing up, it has not yet shown up yet, we start to see higher fevers north of 39 Celsius and headed towards 40 Celsius. In contrast to some of the other viral exanthems, fever tends to be at its height when rash first appears, and rash is likely to first appear on the head, particularly behind the ears. A few quick hits for us to look at together: Koplik spots and morbilliform rashes. So Koplik spots are these intraoral findings. Hopefully I've convinced you that it's important to look for them. They're these small grain of sand size white spots surrounded by a red halo. The spot to look for them is opposite the lower molars. They can show up on the palate, but they're more likely to show up on mucosa. They're present in about 70% of people who have measles, so it's worth looking for. You'll see them potentially in large clusters, as in that patient. They can sometimes look like they're clustered together, the same way the measles rash will be. That's also pretty common. They don't wipe away. So if you try to wipe them with a Q-tip, they'll stick to the inside of the buccal mucosa. They can be extensive, as they are in that patient, or really scattered, as they are in that patient. So easy to miss. They can be teeny tiny. They're historically described as blue-white. I don't really see the blue. To me, it doesn't show up. And so I typically teach that they look like white grains of sand that are just really stuck on the inside of the cheek and often have a little red halo around them. To show you what it looks like in people without teeth, so little kids who have not yet grown their teeth in, you're going to look same spot, buccal mucosa back near the back ridge of the gum. So this is seen in like a 6-month-old infant. You can see the Koplik spots on the cheek at the top there. This is a 9-month-old infant. You can see the teeth buds there, and you can see the Koplik spots coming out. As patients get older and start to have a few teeth, you'll see that the clustering remains in the same location and that the appearance does not vary very much based on how much melanin you have in your skin. Koplik spots look about the same no matter how melanated the patient is. One thing that commonly comes up is, okay, but there's a million things that can give you oral lesions. And the main mimic of oral lesions with fever that people think of are hand, foot, mouth, and herp angina. Typically, Koplik spots are not associated with oral pain or a sore throat, and both herp angina and hand, foot, mouth disease should be. In addition, mucosal lesions from enterovirus infections like herp angina and like hand, foot, mouth tend to be clustered much more heavily on the palate and much less heavily on the buccal mucosa. They also tend to have a slight yellowness to the exudate on them, and they tend to be much bigger. So in this example, we've got Koplik spots here on the left side of the screen, and we've got herp angina here on the right side of the screen. Koplik spots also essentially never invade the lower part of the palate. So in the picture of the herp angina that we've got on the right side of the screen, you'll see that there's a lesion going down towards the uvula. You'll essentially never see that with Koplik spots. Koplik spots like to stay on the hard palate, maybe a titch into the soft palate, but nowhere near as low as that, and they won't hurt, which both herp angina and hand, foot, mouth disease should hurt. So there's those enteroviral mimics are ouchy, whereas measles is not. Questions or concerns about Koplik spots? All right, jumping forward to our skin manifestations. Our classic measles rash is this head down spread of pink to red macules. There are other morbilliform rashes. In fact, there's a lot of them. So erythema infectiosum, rubella, enteroviral rashes, roseola. So that's parvovirus B19, adenoviruses, all of those drug rashes, all of those can cause a morbilliform rash. So what helps distinguish measles? That head down spread. It's brighter and brighter red each and every day. It becomes progressively confluent. It often starts behind the ears, and they tend to have a high fever still and look fairly miserable when the rash starts. So if the kiddo is running around the exam room and they don't have a runny nose, that red rash is not measles. They're going to have either a runny nose or runny eyes. They're going to look fairly miserable, and they're going to be reasonably cranky. And the rash is going to have started on the head, particularly behind the ears, and spread downward. Let's look at some examples together. So You have probably all seen in a textbook somewhere one, if not both, of these photos. These photos are both in the public domain. I like them for teaching because neither one of those children looks chipper. Neither one looks like they are having a particularly good time. They both look like somebody just wiped their nose, but that it's about to start running again. And both of them have sort of that watery eyes, although the little girl on the left side of the screen has much worse conjunctivitis than the little boy on the left side of the screen. Both of them look like they don't feel good, which is part of that sort of like clinical recognition that I want you guys to get into. Measles has looked the same over its entire history. This first image is a painting of a child with measles. The second image is a photo of a child with measles from the 1970s. And this last one is a photo of a child with measles from the past 15 years. So measles looks the same no matter when in time it has occurred. It does look potentially a little harder to identify on a child or adult who has more darkly melanated skin. The rash is the same. There's just slightly less contrast between the pink rash and the tone of the skin than there is in a child who is very pale. So all of these children have measles. All of these children have relatively confluent rash on the face. All of them have that conjunctivitis and coryza that goes along with the rash, and all of them look reasonably unhappy. Some more pictures of children with measles rash. Both of these are children who have had measles for a few days, and you can see that it's becoming progressively confluent over the torso and face. It looks similar in adults. So when adults get measles, it looks very similar to how it looks in kids. You can see that this adult or near adult with measles has relatively confluent rash on the face that then gets patchier and patchier as it goes down their torso into their abdomen. It looks similar in age groups sort of across the amount of skin pigmentation spectrum, typically very dense on the face and then very dense spreading down onto the upper torso, getting less dense onto the legs. The photograph of the person wearing the blue hospital gown shows that it can involve the palms and soles. It does not always, but it can do it. These photos here are intended to bring attention to the fact that it could be easier to miss this red rash on someone with slightly darker skin. You've just got to have a higher index of suspicion if you have a febrile coryzal kiddo and make sure that you are really looking for that rash. Again, looking behind the ears is a great place to start. Once you have a clinical suspicion for measles, you're going to want to do the 3 I's of all highly communicable diseases: identify, isolate, and inform. So identification is what all of the lecture up to this point has been about. It's gaining those skills to recognize this disease, which was once incredibly common and now thankfully is relatively rare, but is expanding. Once you've recognized it, it's time to isolate. This is a person-to-person spread disease. Airborne precautions should be implemented immediately for all suspect cases. You also need to discuss with the patient and parents that the rash is infectious and can sicken others, that don't assume that people know. Ideally, patients should be cared for by people who are measles immune and should be placed in a private negative air pressure room. If you can't do that, at a minimum, put them in a room with a door that is closable. Many times, knowing where the patient has been in the several days prior to the rash developing is going to be key to the public health investigation around any case clustering. So it's important to start to ask the patient or their caregiver, think about all of the places that you've been with the infectious person over the past 4 days and start writing them down, because we're going to need to know those soon. Lab testing, the Maryland Department of Health offers testing, as do essentially all state health departments. Preferred is detection of viral RNA by a PCR test. You can send urine or throat or nasopharyngeal swabs. Any of those work. They're the preferred specimen types. Also acceptable is testing by serology, so that's IgM and IgG serology. False positive measles IgM results are common though, so that's less preferred. In our health system, there is an order set for measles. It looks like this. You'll see that it immediately orders ISO for you because it's so communicable, gets you to get the IgG and IgM going, and gets you to do a microbiology state health referral. It has links to the forms that you'll need to fill out. you'll probably need to do more than one swab. The state likes to get both urine and an additional specimen, whether that's nasal, pharyngeal, or other. And the reason that they like to do that is that the rate of positivity changes over time during the infectious period for urine, throat, and oral fluid samples. So they generally like to get more than one sample to maximize chance of catching the disease. When will they be positive? So nasopharyngeal or oral throat swab will probably stay positive for about 10 days. And will actually, if you happen to swab someone on the basis of Koplik spots, will likely be positive even before rash. We talk about measles a lot in relationship to rash onset, but nasopharyngeal or oral swabs are actually likely to be positive during the entire infectious period, as well as a period after that. So generally the whole first 4 days of infection, NP and OPC swabs are likely to be positive. Urine swabs likely come positive around the time of rash onset and stay positive for about 10 days. IgM and IgG specimens, IgG is looking for immunity, IgM is looking for acute infection, but IgM is a less specific test as a serology test and has false positives. It can be detected for about 6 to 8 weeks after acute measles, and the height of the titer does help. We're now going to transition to talking from testing and sort of regular clinical measles, that coryzal, febrile, rashy illness, to complicated measles. So the severity of measles varies widely. It depends on a lot of host and environmental factors. In the US, the numbers that we use is about 1 to 3 out of every 1,000 children who get measles will die. And that will mostly be from respiratory complications and occasionally from neurologic complications. The rate of measles death may drop as low as 5 out of every 10,000 in well-nourished, immunocompetent adults in high-resource settings. But that's not mostly who gets it. Mostly who gets measles is children. The risk of developing severe or fatal measles increases for those children who are under the age of 5, those who are malnourished, especially if they have vitamin A deficiency, which we'll talk about more in a minute, and those with immunodeficiency, especially HIV and AIDS. Complications occur in about 30% of reported cases, varying significantly depending on age and predisposing conditions. Common complications, otitis media, happens in about 7 to 9% of children. Croup happens in a similar, like 4 to 5% of children. And pneumonia. Pneumonia is the most common lethal complication across the world, and happens in between 1 and 6% of children with measles. Neurologic complications include post-infectious measles encephalitis, which occurs between 1 and 4 out of every 1,000 cases, and a terrible disease called subacute sclerosing panencephalitis, which develops years after infection, even if the infection was not severe. It's rare. It occurs in about 1 out of every 10,000 cases, but it's uniformly fatal, and so is a major cause of distress and heartache for parents of children who thought that their child was going to be just fine and had survived measles, only to find out that they have a lethal autoimmune neurologic illness that leads to seizures, coma, and inevitable death. Treatment for measles involves supportive intravenous hydration, antibiotics if secondary bacterial infections are present, vitamin A supplementation, and is starting to involve the use of antiviral medications, including ribavirin, in severe cases that are being treated in high-resource settings. To give you a sense of the time course of when these things happen in relationship to the rash, so if the rash occurs 4 days into the patient being infectious, about 14 days after they were exposed, and lasts for about 10 days, we see that pneumonia tends to appear as the rash is starting to go away on day 4 to 7. Acute encephalitis starts at around the same time, but the risk period lasts a little bit longer. Inclusion body encephalitis, which is something that immunosuppressed people can get, tends to be a little bit later still, several months later, whereas subacute sclerosing panencephalitis can happen up till years later. Measles pulmonary disease, the diagnosis is challenging. Up to 77% of these patients have a normal pulmonary exam, and about 80% of them will have a normal chest radiograph. If the chest x-ray is abnormal, most patients will have a bronchiolitis type pattern. They'll have bronchial wall thickening or tree and bud nodularity if you do a CT. As many as 1 in 20 children with measles will get pneumonia, and while pneumonia is an uncommon complication, when it occurs, it's pretty serious, and it accounts for about 60% of the mortality from this disease. There's some evidence that ribavirin may help reduce duration of symptoms and hospitalization, but it's generally used only for the most severe cases who have escalating oxygen demands. Secondary bacterial pneumonia is also quite common. It's often treated with clarithromycin. The most common pathogen for secondary bacterial pneumonia is strep pneumo. In patients with pneumonia, most of them do well, but there's a subsection of immunocompromised patients who get frequent bacterial superinfection after measles, have a propensity to barotrauma, pneumothoraces and others, high air leak rate, and a very high mortality rate approaching 15%. That's recent data from a French ICU that cared for a large number of patients during a recent outbreak in France. An important note, the chest x-ray does not allow differentiation from other causes of severe viral pneumonia, and patients will often be hypoxemic well out of proportion to their imaging findings. All of these patients should receive vitamin A, and we consider steroids and ribavirin in certain patients who have severe hypoxemia. Why does everybody get vitamin A? Because it reduces death. The WHO says vitamin A should be given in all cases of severe measles, no matter how resource rich your health system is. This is a place where there's a lot of misinformation, so I'm going to underline that point. The WHO says vitamin A should be given in all cases of severe measles. It's age-based, not weight-based dosing. So 50,000 international units if you're under 6 months, 100,000 international units if you're between 6 and 11 months, and 200,000 international units if you're more than 12 months, including if you're an adult. It's given immediately upon diagnosis and then repeated the next day. Measles induces vitamin A deficiency, even in people with good nutrition. And so if there are eye signs of vitamin A deficiency that develop later on, you give a third dose at 4 to 6 weeks. That's relatively uncommon in well-nourished populations, but is quite common in undernourished populations with limited access to eggs or other dietary sources of vitamin A. There is a ton of misinformation out there about vitamin A and measles. Vitamin A does not prevent measles. Vitamin A is not an alternative to vaccination against measles. High doses of vitamin A above the recommended threshold don't make it less likely that a patient will have complications from measles. The dosing recommendations are established over years. It, in fact, recently was determined that it would be unethical to do any more RCTs on vitamin A because the evidence basis for it is so good, but more is not better. The best way to prevent measles vaccination is through to prevent measles is through vaccination. Vitamin A is not a preventative. If anyone is particularly interested in doing a deep dive on the misinformation, I will send you the links. I did not put a QR code on this slide because it hurt my heart to read some of that misinformation. An important thing that has been discovered since the last very severe measles outbreak in the United States is this concept of measles-induced immune amnesia. So measles infections, particularly in children, but we think also in adults, can wipe out the immune system's memory of other illnesses, including influenza and COVID-19. That means that kids who recover from measles are markedly more vulnerable to other pathogens that they might have been protected from before their bout with the virus. This data comes from a big outbreak in the Netherlands in 2013. They analyzed children who had had the MMR vaccine and compared their blood to 77 children who had had measles. 2 months after the unvaccinated children had recovered from measles, what the team found is that having had measles had erased between 40 and 60% of their antibodies against previously encountered pathogens. And something very similar was seen in animal studies where animals were intentionally infected with measles. That means that the measles virus seems to preferentially destroy the B memory clones that usually hold the ability to remember infections and the ability to produce antibodies on demand. In addition, because measles seems to be particularly toxic to B cells in general, incomplete reconstitution of the naive B cell pool after a measles infection leads to this sense of sort of like immunological immaturity. The way that I would explain it to a patient is that the immune system is sort of reset to neonatal status. So a child who's recovered from measles is like a brand new baby who's never been exposed to anything at all and is at really high risk of getting sick were they to be exposed to those infections again. The QR codes link to the 2 articles that I'm referencing here on this slide, because I know this may be new information for some of you. Our last topic that we're going to talk about before we wrap up is CNS disease as the result of measles. So a patient with severe measles can develop one of 3 forms of CNS disease. The first and most common is acute disseminated encephalomyelitis, or ADEM. This is an inflammatory demyelinating disease of the CNS. It occurs in about 1 out of every 1,000 measles cases. It often results in permanent brain damage. It's described more in adolescent and young adult cases and typically presents 3 to 10 days after the rash. The incidence of this associated with measles infection, as I said, is about 1 in 1,000. This has happened after live measles vaccination, but at a rate of approximately 1 in 2 million cases. CT scan in these cases is usually normal. The patient is acutely encephalitic, confused, altered, may have seizures. MRI is the gold standard for diagnosis, tends to show hyperintense signals on T2 and FLAIR. They're usually disseminated, and they're predominantly in the white matter. Recovery is not assured. About 10 to 25% of people who get ADEM die, and about 40% of people who get ADEM have some degree of permanent neurological sequelae, which can include hearing loss, vision loss, paraplegia, the development of epilepsy, the development of significant intellectual disability, the development of significant psychiatric disability, including very severe psychotic illness. Our second disease is a subacute sclerosing panencephalitis. Our second disease is inclusion body encephalitis, which is progressive measles viral infection of the CNS. It occurs in immunocompromised individuals. It happens a little bit later than ADEM. It happens a couple of weeks after the rash, and is generally fatal. Also generally presents with coma and seizure. Lastly, SSPE, or subacute sclerosing panencephalitis, is a very rare but fatal degenerative disease of the CNS. It's characterized by behavioral and intellectual deterioration, followed by the development of seizures. It happens 7 to 30 years after measles infection, and it occurs primarily in immunologically normal children who developed measles when they were 5 or less, and is at particularly high risk if you got measles when you were a very young child, so 2 or less. There's recent data on this from California. They analyzed 17 cases of SSPE out of a group of about 1,300 cases of measles in children under the age of 5 that had occurred in California. All but 1 of those 17 cases had died at the time of publication, and the final case was on hospice, unable to move or respond to commands, and critically ill. The average age at infection for those children was 2, and the average age at diagnosis was 12, ranging from 3 to 35 years. So this is a very feared complication of measles for very good reason, even though it's relatively rare. Now, we're just about at the end, and let's say that I have just made you very hungry for even more guidance about measles. If you want to have a sense of what's happening day by day and week by week with measles, the CDC updates the measles case tracker weekly at this URL, which is cdc.gov/measles/data-research/index.html. If you would like guidance for clinicians, the CDC continues to update the healthcare provider page, which is at the QR code shown. It shows up-to-date clinical guidance about testing and therapeutics. In addition, the California Department of Public Health has an excellent document on contact managing and prophylaxis, which may be something that you're asked to do if you manage a case in the ED and you discover that several of the nurses that are caring for the patient, for example, don't know their measles immune status, or you don't know your own measles immune status. To wrap us up in our last couple seconds, I'm going to have you review this case. A patient comes to your emergency department. They have fever, a rash, and recent travel to Texas. This is what the patient's front torso looks like. This is what the back of their torso looks like. And this is what it looks like inside their mouth. And I know you guys are going to be able to make the diagnosis of measles for this patient and keep them from giving it to anybody else. You can see in several of the photos the patient is masked, and we're going to assume the door to the room is closed. I'm going to wrap up here because that's my time. I'm going to say thank you so, so much to everybody who came today. If you don't mind, I know I've shown a lot of QR codes. If you wouldn't mind scanning this QR code, even if you didn't scan any of the others, and take a very brief feedback survey. This lecture series depends on your feedback. I love hearing what people think. I love making sure that the material that I provide is useful to you as frontline clinicians. I hope that this was a good use of your time. I really don't take it for granted that folks come and pay attention and participate. If there are any questions, I am happy to field them in the chat, or you are welcome to unmute and ask them. I'm going to leave on the screen this QR code for just a little bit longer. Feel free to retake the survey if you've taken it after a prior lecture, but you want to take it again to tell me that this measles lecture was all wrong and you needed totally different stuff. Do feel free. That is all right by me. And I'm going to leave on the screen this narrative written by Roald Dahl. One of his children died of measles, Olivia. It was his eldest daughter. She caught measles when she was old enough that doctors at the time probably would have said that she was at low risk of complications. She was 7 and was starting to get better when she developed acute encephalitis. And so she was unconscious about an hour after he first noticed that she was having trouble with some coordination of her hands. And about 12 hours later, she had died. And that's pretty typical for measles encephalitis. It's a brutal disease. And so if you ever read James and the Giant Peach or The Big Friendly Giant by Roald Dahl, which are beloved children's books, he dedicated both of them to his daughter and was a huge advocate for vaccination throughout his entire life. So I share that story with you. Yes, Dr. Hussein.
Sorry, no, thank you. This is really nicely done. And I totally forgot about the SSPE, and I'm beginning to wonder if some of the kids who come in as teenagers with mental health issues, if I should start asking about their measles, if they had measles infections as kids. But I'm not sure if you mentioned that we had our own outbreak in Baltimore. We had an outbreak in 2017. I actually took care of 3 of the 5 kids who came into our ED. What was really nice about it, and that it was a small community, it was kind of a Jewish Pikesville community that was not vaccinated. What was great about that is we have contacts, and we reach out to our contacts over there, and we're able to manage their presentation to our hospital, number one, and then getting mass vaccination done over there. So, I mean, it was really nice that when it stays within a community, but once it starts leaving that, then it's like all hands on deck. Part of what we did for that process was also imagine them coming into your waiting room where you have immunocompromised patients, patients having chemotherapy and other things, and a busy waiting room at that. Like, how are you gonna even spot them? How is how are they gonna be spotted right away once they enter? So we were able to, have the information out to the community that if they do suspect, and they need to call, and then we had a system by which they were actually escorted from the Orleans Circle, which is right outside of our entrance, straight back through a back door into a negative pressure room, because we had to be the site where they got swabbed. I don't know why, but we did. And we didn't do urine, but we did do oral swabs. And none of them had Koplik spots at the time. They all had the rash when we saw them. And it's usually, what I remember is the Koplik spots are almost gone by the time the rash starts. So that picture that you showed of that elderly man, or the older man who had both, I was impressed by.
It's more
So,
common in older adults. In kids, it's true that Koplik spots are almost always gone by the time they're
yeah.
ready, but adults often will have a 1 to 2 day overlap where they have both.
Okay. Okay. So you can catch it. So that's really nice. Yeah. But all these kids end up doing really well. So, but who knows in
That's
7 to
wonderful.
15 years, what could happen?
Yeah. Was that outbreak linked to the big outbreak up in New York that year?
I think there might have been yes, I think it was, because there was a relative who came down, and then it just, went from there. They were
Yeah.
able to isolate pretty quickly, though, knowing that this was happening.
Yeah, what we see over and over again in the US and also around the world is that travel associated with holidays, whether it's Lunar New Year or Ramadan or Yom Kippur or Christmas or any big travel holiday where people go and see family, tends to be about 2 weeks before we'll see a big measles outbreak associated with those travel cases. And the hope is that we won't get back to the kind of frequent large measles outbreaks that characterized the pre-vaccine era, because it is a vaccine preventable illness, and vaccine hesitancy is also a treatable cognitive barrier towards vaccination that I want to encourage everybody. Over and over again, we see that the word of a trusted healthcare provider makes a big difference for vaccine hesitant families and communities. So the more that you are talking about this, even with peers and friends, the better. Any other questions that we can field? I didn't see any in the chat.
Hi, Dr. Pousson. Thank you so much. That was wonderful. Question about the vitamin A. What defines severe measles? Like, is it any hospitalization or?
Any measles that requires hospitalization is by definition severe. Typically, other than fever and sort of fever associated vital signs. So patients can be like a little tachycardic when they're febrile, a little tachypnic when they're febrile, but they shouldn't be hypoxemic. When their fever goes down, their tachycardia should improve, as should their tachypnea. So a patient who's being hospitalized on the basis of abnormal vital signs, or even being observed on the basis of abnormal vital signs, is someone who's going to be considered to have severe measles. Other questions? And I will say the recommendation from the WHO is high resource specific in settings where there is more universal vitamin A deficiency. The recommendation is for universal vitamin A treatment, independent of severity. So folks will know their own communities best. Nutritional vulnerabilities exist all across the US, as well as outside the US. And so it's important to remember that even if we think that somebody is having a nutritionally sound diet based on their habitus, that's not always true. Other questions? All right. I am going to ask that we stop the recording. I'm going to stop sharing.